My name is Cameron Lilly. I'm a scientist with Medicare Silicon Biosystems. Today, I'd like to talk to you about a new test that we've brought to market for monitoring circulating multiple myeloma cells in multiple myeloma patients using a less invasive liquid biopsy technique. We'll first talk a little bit about multiple myeloma, about the disease and the challenges in monitoring and diagnosis therein. And then we'll talk about the CELLSEARCH CMMC, or Circulating Multiple Myeloma Cell test itself. We'll talk about the assay design, how it works and what it does, and then we'll talk about a little bit the cell rescue blood collection tube that we specifically developed for this test in order to preserve our plasma cells. We'll then present the data. This is data from us, as well as I'll be presenting some data from our collaborators at Dana-Farber Cancer Center regarding monitoring CMMCs using this test in patients with multiple myeloma, but also in precursor conditions. And then, of course, since this test is only available through Medicare Silicon Biosystems Commercial Lab Services Group, which I support, I'll introduce that to you as well. And then, of course, we'll open it up for questions. So, what is multiple myeloma? Multiple myeloma is a cancer of terminally differentiated antibody-secreting B cells known as plasma cells. So these cells, for the most part, make antibody secreted into the blood. This malignancy, however, happens when cancerous plasma cells move in to the bone marrow and overwhelm it. They disrupt the entire normal, healthy environment inside the bone marrow, which is required for a number of things in health. The symptoms of multiple myeloma can be remembered using the acronym of CRAB. C is for calcinemia. This is calcium released into the bloodstream due to dysregulation of the bone marrow environment and the normal calcium cycle that takes place inside of it. R is for renal insufficiency. Kidney problems are caused by the release of calcium as well as the antibody protein in multiple myeloma and related conditions. Anemia is the reduction in red blood cells resulting from the disrupted bone marrow environment in these patients. And then, of course, are the bone lesions. The disruption of the calcium cycle in the bone can lead to lesions like those shown on the right. On the right side is an X-ray radiograph of a patient with multiple myeloma looking at their forearm, and what you can see is that there are effectively holes in this poor patient's bone. This is the result of erosion and thinning of the bone in those areas, making the bones very brittle and fragile, and it's very common for these patients to present with fractures, and in fact this patient does have a bone fracture just below the wrist if you look carefully. Neurological damage is also a common secondary symptom in these patients, primarily from the calcium which is released into the blood, since calcium is so important for signaling in nerves. Standard treatment in these patients is an aggressive combination therapy, typically followed by a stem cell transplant, and that's required because the combination therapy is so aggressive, it wipes out the normal stem cells in the bone marrow, so we have to replenish that, typically with an autologous transplant. Prevalence of multiple myeloma, according to the American Cancer Society, is as follows. We anticipate a little more than 34,400 new cases in 2022, and this will account for about 12,640 deaths. Multiple myeloma, however, does account for 10% of all hematological cancers. The median age of diagnosis in these patients is 69, so this is typically a disease of older patients, and the overall risk in the population is low at about 1%. So why are we focusing on this? One of the big reasons to focus on this is there are tremendous challenges in monitoring and treating multiple myeloma patients. This is a very difficult cancer to manage. Right now, with current therapies, which are getting better and better all the time, still, we're unable to truly cure patients with multiple myeloma, though we are working very strongly toward that goal. Right now, the goal is to treat the patient and put them into clinical remission, but we have to monitor these patients because the patients are going to relapse eventually. Monitoring of patients in multiple myeloma and in the precursor conditions does require bone marrow biopsies. So this requires the patients to go in and undergo a painful and invasive procedure on bones in their body, and the bone is already disrupted in these patients, as I've shown you before. So this can be quite injurious. It's also painful and tremendously inconvenient and unpleasant for the patient. Initial testing may be tested late in symptoms if it's not caught by routine blood work, and so at that point the patient is very late in progression. If they present, say, with a femur break or a crush fracture of one of their vertebrae, it's possible that they may already have advanced disease, and so this limits our treatment options and makes it a very serious problem for these patients. And of course, a bone marrow biopsy requires a facility in which you can get such treatment or such a procedure, and patients in remote and rural areas may lack access to these facilities too. So what do we need? We need an easier way to assay this cancer and related diseases that is less invasive to complement the bone marrow biopsy. This will be so helpful in monitoring these patients, and it will allow us to screen patients in precursor conditions to monitor them more closely, to be aware much more quickly if they progress. It would also be ideal for this test to be compatible with downstream molecular characterization so that we can do genetic testing on any of the cells that we may encounter to understand the disease better. So let's talk about the disease process and the development of multiple myeloma and the journey that this disease takes. Plasma cell disease progression, here we're showing it from the left to right, from our normal situation. We're also looking at serum protein, the amount of plasma cells by percentage of total cells in the bone marrow, and MDE here is what we call a myeloma defining event. This would be something like the femur fracture or vertebral crush fracture that I mentioned before, but it could also be symptoms that we mentioned in the CRAB acronym. So in normal conditions in healthy people, we do see a healthy amount of serum protein. There is a small percentage of plasma cells in the bone marrow, but there are some, but there are no myeloma defining events. These patients are happy and healthy. The first step in the process is called MGUS, or monoclonal gammopathy of undetermined significance. This is typically detected by a blood test at first, and what happens is there's an abnormal amount of protein. It appears to be one single monoclonal antibody, indicating that there is a clonal population of cells that is secreting a lot of protein in the body. So we see an elevated serum protein, and we may even start to see low elevated levels of plasma cells invading the bone marrow. So we're up above the normal levels, but we're not reaching greater than 10%. Of course, no myeloma defining events. The next step, some small percentage of the MGUS patients will progress to smoldering multiple myeloma. So here we see a further elevation of serum protein as the disease worsens, and we begin to see very large invasion, or we can see very large invasion of the bone marrow of plasma cells. No myeloma defining events yet. Some small percentage of patients in the smoldering stage will then progress to active or acute or aggressive multiple myeloma. So we have lots of protein being produced by the cancer, we see bone marrow invasion, and we see myeloma defining events. And so these patients are very sick, and they have a lot going on in their bodies as well. EMD, or extramedullary disease, is when the cancer moves back out of the bone marrow, and we start to see, say, invasion of the cancer and the tumors in secondary organs, and you could even have plasma cell leukemia in these patients, in which the majority of cells in the blood become the cancerous plasma cells. And so that can be very, very problematic for these patients. It's a very serious disease. The diagnostic pathway for these diseases is as follows. So we're looking at sort of a timeline and process from diagnosis on the left all the way through treatment selection, treatment monitoring, and remission monitoring on the right. What's highlighted in the red boxes are areas in this process in which a bone marrow biopsy is needed. At diagnosis, this is required to characterize the tumor and understand what treatments may be available or ideal for this patient. Treatment is selected based on that information and then applied. Monitoring the efficacy of that treatment also requires repeated bone marrow biopsies. The frequency of bone marrow biopsies is reduced somewhat in remission once treatment has been successful and the patient goes into remission, but they're still looking at a bone marrow biopsy every 6 months or maybe every 2 years if they're really, really nicely and had a deep, durable response. But we're still talking about repeated bone marrow biopsies in these patients with already interrupted and damaged bone health. And that is where we come in with the circulating multiple myeloma cell test. Circulating multiple myeloma cells are in the peripheral blood of these patients, and capturing and enumerating them allows us to directly quantify these cells in the blood without the need for a bone marrow invasion, and we can monitor this at any step in the disease. There are some complications of this method though. One of those is that normal healthy plasma cells occupy the same biological spaces as cancerous plasma cells. They exist in the bone marrow in healthy people, and they exist in the blood in healthy people too. This is true for patients at any stage in our plasma cell disease progress, which I showed you earlier. So how do we delineate between healthy cells and cancerous plasma cells? We do that using cell surface markers. So if you look on the right, CD138 is a cell surface marker expressed on many cells, but it's also expressed at high levels on plasma cells. So to determine healthy plasma cells from cancerous plasma cells, we employ a second marker, which is CD38, which is expressed at very high levels on cancerous plasma cells. And that brings us to the design of the CELLSEARCH CMMC test, which is available from us as an LDT in our CLIA-certified lab through commercial lab services. A CMMC, as we have defined it, or a circulating multiple myeloma cell, as we have defined it, is a CD138, CD38 positive cell, a DAPI positive cell, but a cell that is negative for the markers CD19 and CD45. How we do this capture and detection is as follows. First, the cells are incubated with an anti-CD138 antibody conjugated ferrofluid nanoparticle solution. This allows us to physically capture plasma cells, all plasma cells, using a magnet. Next, the cells are stained in order to do our detection and understanding of what cells we have captured. An anti-CD38 fluorescent labeled multi-epitope antibody is used to stain captured plasma cells as CMMCs. We use a multi-epitope antibody here because we need to be able to make sure that we can detect CD38 on the surface of these cells, even in the presence of CD38-directed immunotherapy in these patients. DAPI is included to stain all nucleated cells because we want to make sure that what we're counting after we've captured it is a whole and intact cell. CD19 and CD45 are used as exclusionary markers, and that's done using a cocktail of anti-CD19 and CD45 antibodies. These allow us to identify and exclude from our counting cells which may be CD138 positive, which are not CMMCs. So how can we use this? What does it actually look like in patients? So what we're looking at is count data, so enumeration of CMMCs in 4 mL of blood from patients that are either normal age-matched controls on the left of our graph in red. In the middle, we have our smoldering multiple myeloma patients and our MGUS patients, so our patients in precursor conditions. And then on the right in green with the triangles, we have multiple myeloma patients. And we're looking again at a log scale count, each dot representing a patient and the count of CMMCs in their blood at the time of sampling. The data are also presented in the table on the right, but I don't want you to focus on most of it, just really the top few rows where we're looking at the range and the mean of these patient populations. So when we look at our normal populations and our age-matched controls, we see, between 0 and 6 CMMCs in our normal patients, we have a mean of just 0.5. So we have a low background. When we begin to look at patients in smoldering and MGUS, our precursor condition patients do show the presence of CMMCs. The range increases all the way up from 0 to 480, but we also have a mean now of 16. So an elevated mean, more patients have higher counts in precursor conditions. This is further expanded when we then compare this to the patients with multiple myeloma. Some of these patients have tens of thousands of CMMCs. The top end in this particular patient cohort is almost 17,000 CMMCs per 4 mL of blood. And the mean, the average in this group of patients is over 1,150. So this tells us that as we're assaying and comparing different patient populations at different steps in the disease process, we can use CMMCs and we can tell what their counts are, and the counts increase according to disease severity. Well, what about in new multiple myeloma cases? We then looked to see, we counted CMMCs and compared that to the ISS staging in these patients at the time of diagnosis. So we have 3 groups of patients. We have on the left, column 1, we have ISS stage 1, in the middle, ISS stage 2, on the right, ISS stage 3. And again, we're looking at CMMC counts in 4 mL of blood using a log scale. When we compare CMMC counts in ISS stage 1 to stage 2 and again to stage 3, what we find is that there is a statistically significant increase in the count of CMMCs in patients comparing stage 1 to stage 2 and comparing stage 1 to stage 3. So it appears that as your staging, indicating your disease progression or your disease severity is worse at the time of diagnosis, we could expect to see elevated CMMCs. And now let's look at CMMC counts over the patient journey from diagnosis into remission after treatment, and then at the time of relapse. So what we're looking at here is patient populations presented in 3 graphs, CMMC counts on the y-axis again in 4 mils of blood log scale. We have our baseline, so this is at the time of diagnosis. CMMC counts were performed in these patients in red on the left. In middle is our group of patients that were in remission, measured after they had had a response to therapy. And then on the right in blue, we have our patients that have relapsed. They have been in remission, but their disease has come back. What we found at the time of diagnosis is that 98% of patients had CMMCs that were detectable. They were high. The median in this group was 1,111 CMMCs per patient. And yet again, we had some patients that were well over 10,000 CMMCs. When we compare that then to the response to therapy groups, the patients that have been through therapy and are in remission, we see a reduction. They have a lower CMMC count than at baseline. However, when we then compare that again to what happens at relapse, we see a return to elevated levels at relapse. This V-shaped graph tells us that CMMC counts are related to the kinetics of the disease and treatment, and so we have a new assay to test a new compartment of the disease using blood. So how does this compare then to the bone marrow plasma cells, the standard here? So what we did here in these patients was we compared matched samples of CMMCs on our y-axis to bone marrow plasma cell percentage by flow cytometry on our x-axis. Our newly diagnosed patients are in red, our patients in remission are again in green, and our patients that have relapsed are in blue. In newly diagnosed patients, we do seem to see a loose positive correlation between CMMC counts and bone marrow plasma cell invasion. However, one of the biggest take-homes of this particular graph is actually looking at the patients who had no detectable bone marrow cells by flow, but had detectable CMMC counts. There are numbers of patients that are smashed up right on that y-axis. So no bone marrow plasma cells detected, but we did see CMMCs in these patients. And so this gives us confidence that this compartment of the disease can tell us information about what's happening in these patients that a bone marrow simply can't. So these two assays complement each other. So now let's compare what we've learned about counts to progression-free survival and overall survival in these patient cohorts. Our patients in these stratified into 3 groups. We have the CMMC 0 group, so these were patients with no CMMCs. We have the mid CMMC group, that's in green in both graphs, and these are patients which have between 0 and 100 of CMMCs in their blood. And then we have our CMMC greater than or equal to 100 group, and these are presented in red in both graphs. Looking at progression-free survival, if we compare the black CMMC 0 graph line to the green CMMC midline, we find really no difference in progression-free survival. So the time to progression in these 2 cohorts was about the same. However, when we compare time to progression to the CMMC 100 or greater group, we see a dramatic reduction in time to progression, indicating that higher CMMCs are correlated with a shorter time to progression. Well, what about survival? So if we compare on the right and we look at overall survival in these patients, in our CMMC 0 group, they all survived. We had no losses of life in that group. The CMMC mid group, between 0 and 100, we saw some, but again, we see a further reduction in the CMMC 100 or greater group, indicating again that higher CMMCs give you a worse outcome. So overall survival was also statistically significantly reduced in the CMMC 100 group. So this assay gives us some confidence that we can understand this disease and the patients with it in the blood compartment with this test. Our collaborators at Dana-Farber Cancer Center decided to take this assay and look at precursor conditions, look at MGUS and smoldering multiple myeloma patients, and then see if they could take the test and do some downstream molecular testing with the cells that were captured and counted. And this, of course, the citation is presented here, and if you're curious about the original source material, I absolutely encourage you to go check it out. So, first, they captured peripheral blood from 185 patients, and then used the CMMC test to enrich and count these cells to get an idea of what the CMMC test results in MGUS and smoldering multiple myeloma patients in their study were. They then used another piece of equipment that we at MSB have developed, and this is called the DEP array, which is an extremely precise cell sorter, allows us to get very pure, in fact 100% pure, either small pools or single cells from molecular analysis, and they use the DEP array to capture the CMMCs and compare them to normal cells to get an idea of what the mutational landscape looked like in those. I'll summarize that data later, mostly for time, and again, I invite you to check out the original study. So, let's look at CMMC counts in precursor conditions in their study. One or more CMMCs was detected in 84% of all patients enrolled. If we're looking at the graphs, we can see here our patients in MGUS are presented in blue, our patients in smoldering multiple myeloma are presented in red in each case. What they found is that 74% of patients with MGUS had one or more CMMC, and 84% of patients in smoldering multiple myeloma had one or more CMMC in the assay. If we look at the bar graph on the left, we can kind of get a sense of how the patients are spread across the counts of populations. Each patient here gets a bar. The height of the bar represents the count of CMMCs in that patient. We can kind of see that the taller bars tend to be smoldering patients and the shorter bars tend to be smoldering patients. If we compare that to the violin graph on the right, we can see very clearly the distribution of CMMC counts in these patients are different between MGUS patients on the left in blue and smoldering multiple myeloma patients on the right in orange. The medians are different in these patient populations. In MGUS, the median was just 2, but in smoldering, the median was 13. These two groups are, in fact, statistically different from each other. So the CMMC test can be used and can tell the difference between MGUS and smoldering patients, and smoldering patients tend to be elevated compared to MGUS in this study. If we look and compare CMMC counts to typical clinical parameters, this is what our collaborators found. So they compared CMMC counts in their patients to M-spike, which is the amount of antibody protein made by the cancer in these patients, and to bone marrow plasma cell percentage in these patients. So match bone marrow and plasma samples to the CMMC counts, and then look to see if there was a correlation between them. And what they found, if we look on the left, CMMC counts on the y-axis in both cases, and M-spike on the x-axis left, BMPC's percentage on the x-axis on the right, we find no correlation. So the CMMC test doesn't correlate to these standard parameters. This tells us that we're looking at a novel compartment of the disease, so we're accessing information that these other clinical parameters simply don't catch. What about risk classification? The risk in smoldering multiple myeloma is a big point of discussion and active work in the field because we want to know what to do with patients at different risk stratifications. Do we need to treat them, etc.? And understanding how CMMC counts in patients at different risk groups may give us information we previously didn't have access to without this test. So the smoldering multiple myeloma patients were stratified according to the 2020 model. The low group is presented in the box and whisker plot down below in the blue on the left. Intermediate risk is in the yellow in the middle, and our high risk is in the red on the right. The medians, comparing low, intermediate, and high, we see sort of a stepwise increase. Median in low was just 4, median in intermediate was 21, and median in high was 59. But then again, if we look at CMMC counts and look to see if they're really different from each other according to risk stratification, we find that low is statistically different from intermediate and high. So both high and intermediate are statistically significantly different from low. So CMMC counts are elevated in intermediate groups and in high groups compared to the low groups. As I mentioned, our collaborators went on to isolate the CMMCs and compare the genetic landscapes both to healthy cells as well as to bone marrow plasma cells to get information about where the CMMCs were derived from and what is happening with them at a genetic level. We're going to summarize that data here for time, but again, I invite you to please go out to the original materials cited below if you want to see the more detailed analysis, which is very, very fascinating. But in brief, CMMCs, when we compare copy number variations or CNVs and arm level chromosomal translocations, what we find when we compare those to bone marrow plasma cells is that they have the same background of mutations of CNVs and arm level translocations. This indicates to us that the CMMCs are in fact derived from the bone marrow. However, we do see they did see additional novel CNVs and translocations in the CMMCs which were not present in the bone marrow population. So the CMMCs are accumulating mutations in their study, indicating that understanding of the CMMCs and the biology therein may tell us something about the disease process that we can't understand with the bone marrow alone. So, talked a lot about what the CMMC test can do. So where can you get it? The CMMC test is only available through Menarini Silicon Biosystems Commercial Lab Services Group, which I support, which is why I'm talking to you today about it. So I'd like to introduce you to our Global Commercial Lab Services Department. We have two facilities. One is in Bologna, Italy, and the other is just outside Philadelphia. Our facility in Huntington Valley, just outside Philly, is a CLIA and CAP certified laboratory providing this lab-developed test to you. It's available right now. Something very special about the CMMC test is the blood tube, the blood collection tube, which we developed specifically for this. Plasma cells are fragile. They don't particularly like being collected. They have a tendency to lose expression of markers or provide difficulty in being preserved. So we had to take a lot of work to develop a tube that could stabilize those cells to get them to us to our facilities. And we ended up with a blood collection tube known as the cell rescue tube, which provides 120 hours of stability for those cells, allowing global service. Wherever you are on the globe, you're within a 120-hour shipping window of one of our facilities, so we can run this test for you and on your patients. Ordering this test from us is fairly simple. We would get you set up with an account on our portal. You would request the test boxes, collect the blood from your samples, and ship it back to us. Once we get it, the samples are tested extremely quickly, and we are extremely proud of our 2-day turnaround time for results. We will get that report to you very, very quickly so that you have the information to understand what's happening in your patients. Now, for a research use only setting, there are other options available. Those are not part of the CMMC test of the LDT, and they are not CLIA-CAP certified. So those we will not be talking about today. So the CMMC test really has access to a biological compartment of plasma cell diseases in the multiple myeloma pathway that it seems like the other tests don't, and it has tremendous potential to meet a less invasive test need in these diseases. And of course, we at MSB, who have developed it and are the sole providers of it, are uniquely positioned to help you bring this into your testing arsenal, to partner with you, to help you on your decisions and your journeys with your patients. And with that, I'd like to thank you so much for your attention. Thank you for joining me today, and I'd like to open it up for questions.